making a large open incision. The incision's maybe 1/2 inch. Both of these procedures are done as an outpatient surgical procedure with local anesthesia, pretty minimal risk. This is just a slide I threw in there. It should be treated by medical professionals. If not treated, symptoms can be more severe. I had 2 patients come into my office today that were being treated by, one was a chiropractor and the other was an acupuncturist. And I'm not saying that these medical, non-medical or ancillary medical people have no role in treating this, but both of these patients were treated for a long period of time, and at that, when I saw them today, the nerve was both of these patients had such severe compression of the nerve that the nerve was irreversibly damaged. So there's a risk in treating carpal tunnel syndrome to the point where the nerve gets irreversibly damaged. And then even with surgical intervention, the treatment is not as successful as it would have been if we would have treated it earlier. So it's very important early on to treat it conservatively, but once that treatment has failed, it's very important to get that pressure off the nerve before the nerve gets irreversibly damaged. This just shows the open technique, and you can see the nerve, and this has got a typical hourglass deformity. This is a normal sort of dimension of the nerve, and this is where that ligament that we talked about was divided, but look at how severely compressed this nerve that it hourglasses out. I mean, that's just not going to get better at this point with conservative treatment, and that's why surgical treatment was necessary in this patient. Again, this just reiterates what we talked about with the aim of surgery dividing the ligament that forms the roof of the carpal tunnel. And this just shows that ligament right there, basically. And the endoscopic carpal tunnel, which I've become a significant proponent of over the last 8 to 10 years that I've been doing this procedure, and I'll explain why. This is done through this tiny small incision here that allows this endoscope, which has a blade attached to it, enter within the carpal tunnel. And by elevating this blade or using this blade to cut this ligament from inside, you're really minimizing the trauma to the hand. No large incision as we saw in that open technique, just a tiny incision here, and the only thing that gets divided is that transverse carpal ligament. So the advantage of this obviously is the recovery is almost half the time as it is with the conventional open technique. And this just shows the same depiction. Here we're looking inside the carpal tunnel with the scope, and we see this ligament. A blade gets elevated and it cuts the ligament across. It's about a 10-minute operation. I think that's all I wanted to say as far as an overview, and I'll pass the baton over to Jeannie to discuss some of the preventative treatments and other conventional treatments available to us.
For 1 minute, I'm just going to skip ahead several slides because I don't want to repeat anything that Dr. Garage has already discussed in very good detail. I just want to show you this one because